We will go now to the second part of this summit. We have with us Dr. Ibrahim Almaghlouth. Maybe most of you know Dr. Almaghlouth. He's an assistant professor in rheumatology unit, Department of Medicine, College of Medicine, King Saud University. He's an assistant director of the College of Medicine Research Center at King Saud University, and he is the principal investigator of the National Prospective Cohort of Lupus in Saudi Arabia. Dr. Almaghlouth is very active in the field of lupus, and he will talk tonight about the propensity score method in systemic lupus erythematosus. So welcome, Dr. Ibrahim, and chair for you now.
Thank you so much. I'm humbled صراحة to present after my great mentor, Dr. Zahi Touma, who's a great key asset in anyone's in any rheumatologist at University of Toronto, and I had the pleasure of working under his supervision and be mentored from a research perspective. So it's also challenging to speak after a great speaker. However, especially when the topic is more related to methodology and statistics. However, I'll try to focus in this session on simplifying these methods that we commonly see in observational studies, including many of studies within the scope of rheumatology, using some examples. Now, the outline of the study is the following. We'll talk about an overview of a propensity score. So what does it mean? When you hear about it in some studies like Euro studies and damage index and the impact of belimumab on damage index, or other studies. We'll use an example of two studies that use propensity score in the field of lupus, and how these methods help to address certain threats to the study conclusion, and including a study on the impact of immunoglobulin, or study on immunoglobulin level and risk of clinically relevant infection, as well as the organ damage in patient treated with belimumab versus standard of care that Dr. Zahi Touma highlighted briefly in his talk, and then finally we will open the floor for discussion. Okay, so what is the learning objectives? I hope that at the end of this presentation, you will be familiar with the principle of propensity score. You'll be at least capable to know when to use such method if you want to conduct a study and you are concerned about confounding factor. And then finally, understand some of the challenges related to the use of this propensity score. So when you read a paper that uses propensity score, you can criticize it in a proper way, or critically appraise it in a proper way. Now, I don't have any relevant disclosure to this talk. However, we received some educational fund from a pharmaceutical company in our unit of rheumatology. Now, the first question, when we talk about any methods in research within the field of rheumatology research, is what kind of studies are we trying to conduct? Well, we know that the impact or the evidence using clinical trial is much more stronger. The reason being of favoring such kind of study design is that the impact of the treatment or exposure, the drugs that we saw, is mostly attributed to the drug, rather than any other features that the patient has. And that's because when we do a randomized trial, we randomly assign a treatment. So the treatment assignment is done randomly, and that allows the balance between both treated group and untreated group in terms of all variables other than the treatment. So the effect or the outcome that we see is mostly attributed to exposure or the treatment. However, that's not always feasible. Clinical trials usually limited by one, requirements of large sample size, and within the scope of rheumatology, we tend to have uncommon diseases, so the sample size may be a problem. Two, it requires a lot of financial coverage, and three, not every question can be answered by a clinical trial, i.e., some of the questions requires a long time, so the outcome is measured after a long observational period. So that's particularly relevant to cardiovascular outcome, osteoporosis, for example, infection risk or malignancies. And these are best studied through observational studies, for example, cohort studies. Now, the problem with these studies that people usually criticize is that inherited notion of confounding bias. So what is confounding bias? And this is a very simple reminder about confounding bias. So confounding bias simply is that it's a distortion, or it's a negative effect, or it's a distortion of the estimate between an exposure or outcome. In another way, when I want to study an effect of a treatment on a population, for example, if we use here paracetamol, and we want to see the impact of paracetamol on asthma, if we look at simple association, we might find an association between paracetamol use and asthma, either positive or negative association, depends on the data that you have. But this association, this relationship may not be true because it is related to another factor that has not been accounted for in the study design. And this is what we call confounding factor. For example, here is fever, where fever is related to the use of paracetamol. We use paracetamol when people have fever. However, fever is also related to asthma because it is associated, it is one of the features of asthma. And it is not on the causal pathway. It's not in the pathway between paracetamol and asthma. So that's what we refer to as a confounding effect, a confounding factor, and the impact of unaccounting for this factor is called confounding bias. Now, the problem is you can easily see that this can be applied easily in most of the observational studies within rheumatology. We know that many of the treatments that we tend to utilize are usually utilized because of a reason. But the reason why I choose, for example, that Dr. Zahi Touma gave on his patient, the reason why he used belimumab, for example, rather than tacrolimus or any other treatment option, was related to factors that he mentioned, or some of the factors that maybe did not mention. For example, if he did not have availability of tacrolimus in his institute, and that's just a hypothetical example. And unaccounting for these factors can result in distorted estimates between the relationship between of treatment, for example, and the outcome. Now, in order to account for this, we usually use a couple of options in a standard fashion. So the options are, we do something called matching. So you match people with certain factors and other with other factors. So you keep them similar to each other, except for your exposure of interest. So for example, here, a drug like belimumab, we can use restriction. So we eliminate patient that has features that may not fit the study scope. We can do stratification, or we can do something called regression model, which is commonly used in statistical model. These factors may have some drawbacks and may not account for all the confounding factors. That's why another approach was introduced by Rubin in 1983, which was called a propensity score. So what is propensity score? Propensity score is simply a score that is ranged between 0 or 1, which reflects the probability of receiving the exposure of interest, so receiving the treatment of interest, given to all the patients within your study, irrespective whether they receive the treatment or not. So in another way, if I know the factors that led to led Dr. Zahi Touma to choose belimumab rather than any other treatment, and we want to compare belimumab to whatever other to standards of care, for example, if I know all these factors, I can create a model using something called logistic regression, and this model will give me a probability, which is a score between 0 to 1 or between 0 to 1. And this will reflect the probability of the individual in this cohort, in this large population, whether they are the population who received the treatment or those control group did not receive the treatment, of receiving the treatment. And why is that important? Because in such way, we make both study population, the exposure and the control, the interventional arm and the non-interventional arm, both study groups similar in almost all factors except the exposure of interest. And by that, we reduce the confounding effect. Now, this is the idea of propensity score. It is commonly used in one of 4 methods that we'll mention briefly. This nice demonstration reflects what is the propensity score. So let's say that this is our study population. So whole thing is a study population. We have a treatment group and we have a control group. You can see that everyone in the whole cohort, after creating this model based on all the variables that we think might affect the relationship between the treatment and the outcome, are entered within this model. We give a number, which is reflected here by 0.12, 0.26 for each individual based on how likely this person is going to receive the treatment based on all the variables. And then we make sure that both treatment groups are similar in terms of this number. By doing so, we ensure that all the variables that was used to build this model or to give the propensity score are similar and reduce the confounding factor. Now, there are 4 ways usually commonly used for propensity score, and there are more advanced ways. We'll not go into the details, but the most common is the propensity score matching. So you make sure that both groups are similar. So you match each individual with 1, 2, or 3 individuals from the control group with similar propensity score. So you can see here 0.31 and 0.3, 0.15 and 0.14. Usually the matching use something called caliper. So that means how far do you want, what is the difference, with absolute difference between both propensity score. And sometimes we use, so that's one of the methods that commonly used. The drawback of this method, obviously, is that some of the people, for example, in this example, the ones that not circled, has to be excluded from the study because they have no matching to them within the treatment group. So in another way, you might lose some power, and you might create, some people will argue that we are not seeing the total effect included because those people who are excluded might influence the result in a way or another. So that's the propensity score matching. There is propensity score. There is stratification, which is essentially matching within small subgroups. There is adjustment. So you include the propensity score in a simple regression model similar to any other variable that we use in usual regression model. And by that, you account for the effective propensity score. And we have something called inverse weight probability treatment, inverse probability weighted treatment. And this method simply ensure that everyone is included. And the way it works, we give the one with the highest score of propensity score tend to get, from the treatment group, tend to get lowest weight. So we divide we give 1 over the propensity score, and those with lowest propensity score tend to have higher weight in the analysis. So those with lower lower propensity score tend to have higher weight, and those with higher score tend to have lower weight. In another way, we make sure that both groups are similar and balanced, and by that we reduce the confounding effect. Now, I think that this is a very important point. Moving from that part, the question to each individual is, what do I need to do when I read a paper with propensity score? So this is a very simple algorithm that essentially ensures that you go over several steps that we usually use to construct propensity score, and usually very helpful to ensure that the people, whenever you read a paper with the propensity score, or you want to do a study that uses propensity score to adjust or account for confounding effect, are done in a proper way. So the first step is to make sure that the variables, all the things that are used to create a propensity score, are included within the model. In another way, if you think, for example, in a study between belimumab and placebo, for example, that disease duration is important, and you do not find it included in the model, then you say, I'm not sure that propensity score was done right. So this is just an example. So you look at the variables included in the propensity score. 2, you make sure that the propensity score is done in proper model. Third one is related to what kind of method the propensity score was used for. We usually believe that using more than one method is better, because that gives robustness to the results. Make sure that it was not just statistical association, or statistical influence, but rather true finding. We use matching, adjustment, and the third thing, stratification or weighted. And then the third thing, which is very important, once they use propensity score, you have to look at the table where they describe the patient, the treatment arm and control arm, the exposure arm or the control arm, before they do any propensity score method and after they do any propensity score method, and see that the balance, the differences between both groups have been reduced, so the propensity score did what it's supposed to do. And that's a very important part. And then you look at the treatment estimates. I think that this is just too much information related to statistics. I'm sure you are bored, so let's get a couple of examples. So the first study was our study on the acquired low immunoglobulin level at risk of clinically relevant infection in patients with systemic lupus erythematosus. The question in this study was, the clinical question that we had was, well, we know that infection risk infection is a major cause of mortality in patients with lupus, and it seems, as the Dr. Urwitz always say, that the impact of infection on mortality is persistent throughout time. So, i.e., whether you are diagnosed early or late, there is always the risk of infection. And despite the fact that people use immunosuppressive agents, which by default increase your risk of infection, including steroid or immunosuppressive agents, we know that some people develop infection, others do not develop infection. So there must be something else that accounts for infection risk. One of these variable factors that we looked at is the level of immunoglobulin. The question was whether acquiring low immunoglobulin, a drop in your immunoglobulin, increase your risk of clinically relevant infection. The problem that we face when we conduct such study is that the people who develop low immunoglobulin are unlikely to be similar completely to a patient who do not develop low immunoglobulin. And this difference in patient characteristics may account for the risk of infection rather than the low immunoglobulin itself. So in order to ensure that there is balance between both study groups, we decided to use a propensity score method in different ways. We used propensity score matching, adjustment, or inverse probability weighted. Without going in the details, this first table reflects the impact of the propensity score on the study population. So for example, you can see on the most important variables that we think might increase your risk of infection based on the literature review, you can see that there is difference between patients who had no low immunoglobulin ever throughout their follow-up and those with low immunoglobulin in their follow-up. Now, because of that, for example, steroid is different, immunosuppressive agents are different. Because of that, and we look at the difference using something called a standardized difference, which is one of the ways to look at the difference between both groups. When the standardized difference, or what we would sometimes refer to as the bias, is more than 0.1 or more than 0.5, they consider it to be significant difference that may result in significant threat to the study. So you need to account for it. And what we did after the propensity, by using propensity score, you can find the standardized difference is significantly less compared to what was it before. So you can see that the numbers are going down, whether we use propensity score matching or we do inverse probability weighted treatment. And most of the numbers are below 0.2, which seems to be adequate. Some people argue about the cutoff points of standardized difference, but less than 0.2 is decent, less than 0.1 is even better. Okay. So in that study, essentially what we found is that acquiring low IgA was associated with increased risk of relevant infection within 2 years of follow-up, rather than IgG or IgM, noting that the numbers of infection rate was really small. So even if there is an impact of any of these, the impact would not be huge and definitely limited by the sample size. But yet, we found some differences with low IgA. Now, the question is which method to use. This is another paper that we published last year that looked at the different methods and the performance of different methods. The summary of this, paper was probably using more than one method is better than none. There is advantage of each method, whether you use matching or inverse probability weighted treatment or advanced method and adjustment. Adjustment by itself may not be the best method, and you can see that inverse probability weighted treatment had the more conservative and precise estimate, as well as to lesser extent matching. And that was just a simple example of how we can use these methods, even though we don't have a large data set. So this was one of the common criticism about the use of propensity score. You will find it more commonly used in population-based studies that use population-based data sets. Okay. Now, the second example, and I'm not going to take a lot of your time, I know we are close to finish, is really the study by Dr. Urwitz and his colleagues on the impact of belimumab on the acromegaly damage over time. The question that they had in mind, which is an important question, in lupus, when you acquire damage, that increases your risk of further damage, and two, it is associated with increased mortality. So it's a surrogate marker of a very bad outcome. And that one of the main targets of therapy is to prevent damage. Now, damage is related to multiple factors, obviously, and it will be an important outcome to have besides achieving clinical remission. So you might be happy to achieve a clinical remission with, for example, high doses of steroid, but that will not be a very good targeted outcome, a very important outcome, because you want to prevent damage, and we know damage is associated with very high doses of steroid. So another way, can belimumab reduce the risk of damage independent of all the other factors that can contribute to damage? Now, obviously, patients who received belimumab are not similar to the people who did not receive belimumab. So their way to account for this imbalance or confounding effect is by using propensity score. This study was clearly done well. They did multiple methods of propensity score. The study was published in 2019, and essentially they compared pooled data from the clinical trials of belimumab to a historical cohort of Toronto lupus cohort, and they tried. The first question that you will have in mind is, well, Toronto lupus cohort may be completely different than the patient with who were enrolled in the BLISS trial, and that's absolutely important observation, and that's why they use the propensity score to ensure that both study groups are similar in all factors that they can think about, except for the treatment, which is belimumab. And as we learned previously, the first thing is to look at the factors that was used to build the propensity score. And this slide highlight the factors. I know it is a busy slide, but they looked at the most important confounding factors that can contribute to the use of belimumab. For example, the amount of steroid people are on, the immune suppressive agent that they are on, the disease activity that they have. So they looked at all these factors and they used it to build the propensity score. And before the propensity score, you can clearly see that people with belimumab and people who use standard of care from Toronto lupus cohort were significantly different. You can look at the bias. Anything above 10% is considered to be important difference. Are different, including immune suppressive agent or the use of steroid or the baseline disease activity, etc. after they use propensity score, you can see that the difference is less than 10%, and even less than 0.5, less than 5%, which is excellent balancing that we can see with the use of propensity score. In another way, all groups are similar except for the use of belimumab, as if they created a pseudo randomization or a pseudo clinical trial. And then the study, obviously, outcome was reported, and what they showed is that the use of belimumab, for example, was associated with reduction in acral damage over time compared to standard of care. Having said that, there are always some concerns when it comes to the period where those patients were observed. Toronto lupus cohort was observed over a longer period of time compared to the clinical trial, which was done recently. But that being said, they did excellent job with using multiple methods with a propensity score to ensure that they account for all potential biases, and the signal was persistent. So these are the sensitivity analysis that I was referring to, and without going into the details, it was very well done, I think, in my opinion. So I know that we are close to time, and there is nothing boring than talking after, first of all, Zahi Touma, who was a great speaker and full of knowledge and wisdom, and two, talking about a statistical thing in rheumatology. But to summarize, the first thing when you read any observational study is to make sure that they did everything in their power or in their ability to account for the biases that may result in inappropriate or inaccurate estimate of association between something and something else. One of the most important things is to be looked at in any observational studies. One of the methods to be used is propensity score. It's not the answer for all, but it is one of the methods. There are different ways to use it. Most important thing is to look for what is going into the propensity score, that these are your confounding variables, and then you look at how are the similarity, so the balancing between the both study groups after the use of propensity score, and then try to take this into account when you look and read the paper. With this, I conclude the talk, and I'm happy to receive any questions. Thank you.
Okay, thank you, Ibrahim, for your lecture. As you mentioned, when you talk about statistics, sometimes it's difficult for some audience, especially you are talking about something new or not used to do it. But it's good and excellent that, especially that we will have our Saudi registry of lupus. So it will be soon, inshallah, by most likely next week, we'll start launching the Saudi registry for lupus, and already you have the cohort in your hospital. So most probably we'll use it a lot during our publication.